So today I would like to discuss the difference between a typical ARDS and a COVID-19 ARDS, the pathophysiological difference that makes difference in ventilator setting, as well as other sedation protocol and analgesia protocol and septic shock management. So first I would like to discuss the pathophysiological difference between typical ARDS and COVID-19 ARDS. So in ARDS, basically the thickening of alveolar arteriolar membrane because of inflammatory substance released because of secondary infection. So once arteriolar leaking and alveolar wall injury, as some inflammatory cells migrated there, as well as transudative and exudative fluid, the whole bunch of process causes alveolar membrane thickening and fibrosis. This usually causes the loss of elasticity of alveoli, as well as decrease the compliance of alveoli. So compliance decrease means the alveoli cannot take new air that can participate in arteriolar gas exchange. So in typical ARDS, main problem is compliance, decrease the compliance, but no disturbance in perfusion. That's why it is called intrapulmonary shunting, means the blood is shunting from right heart to left heart without getting proper oxygenation because of the thickening of alveolar arteriolar membrane and decrease the diffusion of oxygen. So right heart circulation going to pulmonary circulation through the pulmonary trunk, but not getting oxygenation. So low oxygen blood ultimately drain into left heart and getting to systemic circulation. But in COVID-19 pneumonia, there are different pathophysiology here. So in autopsy finding is proved that the pulmonary hemodynamics is altered, mainly no disturbance in compliance. So some studies shows the compliance really increased in COVID-19 pneumonia ARDS. So if pulmonary alveolar compliance increased, then what's the reason for hypoxemia? So there should be something different pathophysiological process happening in COVID-19 pneumonia ARDS. I would like to give you an idea about some terminology. First one is shunt fraction. So shunt fraction means percentage of blood flow that is not exposed to inhaled gas. So in easy meaning, percentage of blood circulating through the pulmonary circulation but not coming in contact with gaseous exchange. In general, it means right to left shunt without getting adequate oxygen. That's called shunt fraction. So equation of shunt fraction is Qs over Qt. So in typical ARDS, the shunt fraction increased as well, but in COVID-19 pneumonia, the shunt fraction increases in relation to fraction to non-gaseous tissues. So before going to ventilator setting, I would like to discuss about this terminology, oxygen extraction ratio. That's the ratio of oxygen consumption to systemic oxygen delivery. So the equation is VO2 means oxygen consumption in relation to a systemic oxygen delivery that expressed as DO2. So the systemic oxygen delivery again calculated by 13.4 times cardiac output times hemoglobin times arterial oxygen saturation. So the normal oxygen extraction ratio is about 25%. So our goal of oxygen extraction ratio to maintain below 50%. So this is general circulation, this is arterial side, this is tissue, and this is venous side. So in arterial side, oxygen is coming to the tissue, and the arterioalveolar gradient makes the oxygen extraction from arteriolar side to the tissue. So more difference in between arteriolar and venous side oxygen pressure, more oxygen extraction into the tissue. So this formula is important to maintain oxygen extraction ratio as well as to optimize your ventilatory support. So other term I already discussed about shunt extraction, meaning again percentage of blood flow that is not exposed to inhaled gas. So in COVID-19 pneumonia, the alveolar compliance is basically increased instead of decreased. So that is the main difference in between typical ARDS and COVID-19 ARDS. In typical ARDS, again, main problem is elasticity of alveoli that has been lost. But in COVID-19, elasticity even increased. So what's the reason? Hypoxemia. So if I come to VQ ratio, VQ mismatch ratio, so if ventilation is completely fine, then perfusion is the problem to make it mismatch. So in COVID-19 ARDS, there is no problem with alveolar compliance. That means second target is perfusion. So, the cytokine storm and interleukins, those causes vasoconstriction, and due to secondary inflammation and cytokine storm, then another possible reason may be microthrombi formation in pulmonary arteriolar circulation. Those two reasons may alter the hemodynamic status in pulmonary circulation, vasoconstriction and microthrombi in pulmonary circulation. That means main problem is perfusion, not the ventilation. So this pathophysiological concept is very important to optimize your ventilatory setup. So in typical ARDS, the target of ventilatory setup to recruit the collapsed alveoli, increase the compliance of alveoli, secondary to increase peak pressure as well as high FiO2. However, in COVID-19 ARDS, there is no problem with pulmonary compliance. So our target to maintain or optimize the perfusion. So in VQ mismatch formula, our target is optimize the perfusion. So how we can increase the perfusion to maintain optimum oxygen extraction ratio? First, in this formula, we can see oxygen consumption, BO2. So oxygen consumption is proportional to oxygen extraction ratio. So if I decrease the muscle metabolism of respiratory muscles like chest wall muscles and accessory respiratory muscles, then we can decrease the oxygen consumption in total. That's where we can optimize oxygen extraction ratio. So how we can optimize oxygen consumption? To use optimum sedation and optimum paralytic agent, we can decrease oxygen consumption in respiratory muscles like chest wall muscles and accessory respiratory muscles. Second term, systemic oxygen delivery. We can optimize systemic oxygen delivery by optimizing cardiac output, hemoglobin, as well as arterial oxygen saturation. So this is inversely proportional to oxygen extraction ratio. Third thing, how we can optimize perfusion. So we know the gravitational influence on perfusion and ventilation. So in basal zone, the basal zone of lung has more gravitational pressure, gravitational influence. So that's the gravity cause increase perfusion at the base and decrease ventilation at the base, because increased gravity causes increased alveolar pressure. The basal zone of lung ultimately decrease new ventilation. However, increased gravity causes more perfusion at the base of lung. So if I increase the perfusion in whole lung field, we can change the patient to prone position, meaning face downward. So by putting patient in prone position, face downward, we can increase the perfusion toward apex as well as all over the lung. That's the mechanism. By keeping prone position, optimizing gravitational force, and optimize the perfusion, and ultimately we can improve the ventilation perfusion ratio, finally improve the oxygenation in lung tissue as well as systemic circulation. So that's the pathophysiological difference between COVID-19 pneumonia and ARDS. And so if I summarize the ventilatory support for COVID-19 ARDS, the target is improved perfusion by prone positioning. Second thing, decrease oxygen consumption by a proper sedation and paralytic agent. And other secondary thing, we can optimize cardiac output by inotropes. We can increase hemoglobin content by perfusion if patient hemoglobin is low, less than 7. And we can increase the arterial oxygen saturation. Now, the inotropes, which can also influence the oxygen saturation. So if I use beta-2 agonist like dobutamine, in COVID-19 ARDS, then what's gonna happen? So again, if we increase inotrope dobutamine, that can also affect cardiac output, increase systemic oxygen delivery, increase delivery of oxygen to the tissue, and same thing, the oxygen delivery to the tissue is inversely proportional to the oxygen extraction, so that can influence and affect the oxygen extraction. And pulmonary vasodilation may worsen ventilation perfusion mismatching in the lung, causing a slight decrease in arterial oxygen saturation. That's why dobutamine is relatively contraindicated in COVID-19 ARDS. So if patient needs inotropes, first choice is norepinephrine, second choice is neosinopril, phenylephrine, third choice could be vasopressin, fourth choice could be dopamine. So we should not use dobutamine because it can alter the intrapulmonary hemodynamics, and it can increase systemic oxygen delivery. That's the way it can decrease oxygen extraction. I think that will help everyone to optimize the ventilator setup and how to sedate the patient was the goal of oxygen therapy. Thank you very much. Stay strong, stay safe.